Hi, everybody. Welcome back to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Kerry Reller, and today we have Dr. Rebecca Jimenez-Sanders. Welcome to the podcast.
Thank you, Dr. Reller. Thank you for having me here.
Yes. So, why don't you tell us a little about those four phases of the migraine?
Yes, the first phase is the prodrome, and we'll go into that. The second phase is the aura, which not everybody goes through them. Only 25 to 30% of patients actually have aura. Then the third one is the actual headache phase, which is truly what we recognize most of the time as our migraine. And then the fourth phase is the postdrome. I like to think of migraine again, just like we had mentioned before. Migraine is really not just a headache, is a neurologic disorder of brain hyperexcitability. And I like to think of it as a storm. So before it starts, like the sky changes, the pressure changes, the wind changes, and eventually the rain comes. So the same happens with the migraine. In the prodrome, which is that warning phase, that can occur anywhere between 24 to 48 hours before the actual headache occurs. And in this phase, we know now with the new migraine pathophysiology that we know that it's not just a vascular disorder, is really a brain and neurologic disease that starts at the hypothalamus getting activated, and then it goes and activates the brainstem, the trigeminal vascular system, and the pain pathways. So in this first phase is where the hypothalamus gets activated. And our patients start experiencing excessive yawning, fatigue, cravings. A lot of patients say that they say that it's the chocolate triggers the migraines, but it really, we know now that
Yeah.
it's not really chocolate triggering the migraine, is that hypothalamus activation that increases the craving. And a lot of patients may crave carb rich, like foods rich in carbohydrates, sugar, and it's because of that the brain uses glucose. It's a way of being active in the metabolism. And also it has magnesium, so it's also craving those. But it also, in the prodromal phase, we also have mood changes, irritability, depression, neck pain is a big one in this phase, brain fog, difficulty concentrating. One that is also very interesting is the increase in urination and increased thirst. So all of these happen again in this prodromal phase. Then after this, then we have the aura again, that it can occur in 25 to 30% of our patients. And in this part is where the cortical spreading depression occurs. And this is a slow electrical wave that moves across the brain. And that's where we can get most of our symptoms of this visual disturbance that we had talked about prior. And we can see in those the zigzag lines, flashlights, blind spots, shimmering vision. Other sensory disturbance that can occur is the tingling and numbness sensation. And then in some patients, hemiplegic migraine also can occur, which is more of the motor, that they can't move part of their body. This aura phase only lasts about 5 to 60 minutes, and then after this is when the headache phase or the third phase occurs. And again, this is what most of us recognize as our migraine, because it's like the pain where it becomes disabling. And at this point is where the trigeminal system becomes activated, and then all the inflammatory neuropeptides are released. And in that cascade of neuropeptides is where we find the CGRP, the PACAP, which is one of our newest neuropeptides that are being, and we have medications already being designed against this one. We still don't have any out there, but this is the next target for the future. And then substance P. And these are all pain pathways that become sensitized. In this phase, then we have the head pain, and not only the head pain, but also the nausea, the vomiting, the light sensitivity, the sound sensitivity. The smell sensitivity, although it's not in our ICHG criteria, smell sensitivity is something that we see with our headache patients, our migraine patients, very significant. And then movement sensitivity, right? We know that migraine gets worse with movement. After we have gone through the headache phase, then we end up in our prodrome phase, which is what most patients feel like a migraine hangover. And it occurs after the pain resolves. And the worst part is that this also can last up to 48 hours. So if you think about it, these are, again, this is a very disabling disorder because it can last 72 hours as it is or more. In this phase, we see fatigue, brain fog. We see, again, difficulty concentrating, mood changes, and a lot of dizziness as well. So it's like then the storm has passed, but then the cleanup crew is still working. So, and this is exactly what happens. And that's why patients need time to recover from this phase as well.
So funny with your analogy, you mentioned the weather and the storm coming. A lot of patients sometimes say that the
Yes,
weather change and the pressure changes causes migraines. How can
that's
you?
correct. Yes, so there are many theories for why weather changes is a stressor. There is theory that it's like our sinus have receptors for this barometric pressure changes. And there, again, there's multiple theories. I don't think that there's any that has been proven, but it's for sure that weather changes and many of the patients that suffer from migraine can be a trigger. And again, it's more of what we were talking about, this homeostasis, our migraine brains like having everything at a balance. And weather changes is a change again, and the same as hormonal changes and everything, it can trigger already a very hypersensitive brain. And there is treatment for that. I was going to say
Oh,
headache specialists definitely, we know our tricks to help with that.
okay. What's an example?
So we use acetazolamide, methazolamide, but it's not for every patient, right? And of course, we know for especially for this storm season, as we just started hurricane season. So we always advise our patients the same thing. Make sure that you're sleeping well, that you're hydrating well, that you're exercising, making sure that our threshold is not very low so that any change can actually cause a migraine. So we want everything to be at its best so that when these changes occur, then also we have a cushioning phase where not everything is causing the migraines. But some patients really just get they're very much affected by it, and acetazolamide or methazolamide can also help prevent headaches in this phase.
That's interesting. Obviously, that's like the altitude sickness
Mm-hmm.
medication. So if patients
Correct.
relate to more of that comment, I guess then maybe they would realize that it's treating the pressure, the altitude. I don't know. That's interesting that it's used.
And with
Yeah.
weather changes, it really is the rapid drop in the barometric pressure that causes most of these migraine symptoms.
Mhm. We also have a lot of patients in our practice. We do a lot of allergy, right? So they have nasal congestion. And I think sometimes they also think that maybe with the sinus type headache can turn into a migraine. Do you ever see something like that?
Yeah, so that's a very good question. And a lot of our patients come saying that they were misdiagnosed, right? Or they just come complaining or wanting help for their sinus headaches. So that
Mhm.
it's a good point that you bring. You mentioned allergies. So let me just allergies don't really cause migraine, right? It can just be it can trigger migraines,
Right,
but it doesn't really cause the migraines.
right.
The same as a sinus headache. So, sinus headache, by definition, is a headache that is obviously in the sinus areas, but it is linked either to allergies or to a sinus infection with
Mhm.
mucus. And we have multiple studies that have shown that Over 85 to 95% of patients, when they are talking about their sinus headaches, they really meet the criteria for migraine.
Mhm.
So they end up actually having light sensitivity, sound sensitivity. The headaches last for more than 4 hours. And the reasoning is because the trigeminal nerve, which is the nerve responsible for headache pain, also innervates our sinuses.
Mhm.
So it very much feels like it's in our sinus areas, this pain. Migraine does not have to be unilateral, does not have to be throbbing, right? These are specific features that migraine can have. And yes, if you have those features, are most likely that it is a migraine, but it can also be bilateral. I think you have to take into account that light sensitivity, sound sensitivity, the duration of the headache, if it gets worse with movement as well, if there is nausea associated with it
Mhm.
or queasiness, because there is, with migraines, we get what's called gastric stasis, which is like our motility slows down.
Mhm.
So not every patient actually gets nausea and vomiting, but they just may feel queasy and lose
Mhm.
their appetite. So yes, so it's important to differentiate what true sinus headaches are from
Right.
migraines.
Yeah, I think that perhaps those patients are already at risk for migraine, or they just, like you said, maybe a little bit of misdiagnosis, or maybe there's both. But I also was going to have the question of where to tell the listeners where does the trigeminal nerve innervate and things like that, because I think that's pertinent for where we feel our pain sometimes when we have a migraine. So that
Correct,
was a great
very much.
explanation. Yeah. The other thing I think you mentioned was with the hypothalamus and the cravings. And I just don't think we talk about the prodrome about it very much at all. And
Enough,
yeah,
right?
that was
Hmm.
definitely
And so,
interesting.
yes, and I think it's extremely important to, like you said, talk more about it, educate more about it, because now with the newer medications and the CGRP antagonists, they're doing studies that if you actually treat in that prodromal stage or phase, then you actually can prevent the further on the aura, you can prevent the headache phase, and you can prevent the postdromal. So again, going back to how important is to the acute treatment, and we'll talk about the acute
Mhm.
treatment in a second, is treating super. The earliest that you can treat, the better it is. And so understanding, recognizing your own, because everybody's prodromal stage and symptoms is different, is extremely important so that you can
Mhm.
treat properly and treat early.
Yeah, absolutely. I think you are also mentioning some of the older diagnostic features of it, like the unilateral must be throbbing. And as once again, we've learned more about migraine, that it doesn't have to be like that. I thought that was very pertinent as well. Um,
Yes, and they are
mhm.
still. So if you look into the International Classification of Headache Disorders, are like, this is our book for diagnostic criteria, it still names them, right? But it doesn't have to meet all the criteria in those, that it doesn't, as long as it combines the nausea, the light sensitivity, the sound sensitivity, it doesn't necessarily have to be unilateral.
So you mentioned acute treatment and that it's important to be treating early. So what kind of things do we use for acute treatment of migraine?
Yes. The acute, just to make sure that we are understanding, acute treatment is the treatment that we use to stop the migraine when you already started having it, right? Even in that prodromal phase, or it's like putting out the fire. And then the prevention treatment, again, it's preventing the fire from occurring. Again, in this is where we want to use the medications as early as possible, and we have multiple to choose from simple analgesics like acetaminophen, that is mostly used for mild headache pain, pregnancy, although I know there's have
Mhm.
been discussions with the pregnancy and acetaminophen, but it's still used. And then we have the nonsteroidals, anti-inflammatories, that they help block the inflammation. And these, we have the ibuprofen, the naproxen, the diclofenac, the celecoxib, and then we have the mower. specific acute medications like triptans. And in this, we have all the triptans: sumatriptan, rizatriptan, elatriptan, sulmitriptan, naratriptan, and they work in the serotonin receptors. So interestingly, the reason why they work is because they reduce the CGRP release. So in another receptor, they are actually doing what the newer class of medications are doing, which is the newest is the CGRP or GPANs that are CGRP blocking agents. And this is CGRP is like the main chemical right now that fuels the migraine. And again, these medications kind of block that. And that one is we have the Ubrelvy, the Nurtec, and the Saf spread, which is the nasal spray. And so we have all of these, right? And patients may get overwhelmed. What do I use? When? And so I think the beauty, I think, and this is the art of the headache medicine, is that as headache specialists, we formulate plans for our headache patients where we are combining medications because we know that, again, this migraine pathophysiology, it starts in one place and it activates a lot of molecules. And it's really the combination and attacking the migraine from different angles and at different receptors and blocking different pain pathways where we get the best result and we improve the quality of life of the patient. We use a specific migraine medication, but then we may combine it with another NSAID. In addition, we may combine it with an anti-nausea medication. We may combine it with Benadryl as well. So it depends on the patient's comorbidities, the patient type of pain, and the symptoms that they have that we make our headache cocktails specific for each patient.
It's funny you say the headache cocktail because we always use that term like migraine cocktail.
Right.
Yeah.
Yes.
And it's great you mentioned the combination, right? Because I mentioned that I once went to a neurologist for my migraines, and all I needed was to be told to take the NSAID with my Triptan. And that was it. I've been pretty decent since then. So now I always obviously treat earlier than I used to because we were hoarding them so much because they only give you 9 a month. So
That is
why
true.
is that? And how do you work around that? Or
Yes.
do you automatically make sure they try to do the prophylactic if they're needing?
Correct. That's a great question. So they give you very little amount. Sometimes I think they give you less amount that is permitted, but there's a science behind that as well. I know insurance has its reasoning, but it's also we are trying to prevent medication overuse headache. And medication overuse headache is a headache. It was called the rebound headache. It's a headache that is caused by exactly that, the overuse of the medications. And then each of these classes actually have a different amount. So for triptans, we don't want to use it more than 10 days per month. We know that using it 10 days per month or more increases the risk or predisposes you to get medication overuse headache. The same for NSAIDs actually is 15. For NSAIDs is actually up to 15 headache days per month. So this one is more that is allowed, which is good because a lot of our patients that are later in their life, they have arthritis and they have other pain disorders that they need to use the NSAIDs more regularly. So at least with the NSAIDs, it's a little bit more flexible and more days. With the other medications, this like the Furosemide, which is a combination medication, or the Excedrin, which again is a combination medication. These are medications that we can only use 10 days or less, or again, if not, it increases the risk of the medication overuse. With the Furosemide or the butalbital products that we were saying, we try to avoid it. I know some of our patients absolutely need it as a rescue, and it's okay, but definitely try to limit it less than 5 days per month, the maximum. I don't think that as headache specialists, will probably never use more than 8 pills a month as a prescription. And that's if nothing else worked. then that's a second. We like to do like plan A, plan B, plan C, try to avoid patients to end up in the hospital. So we have multiple plans for the patient to go through in order to avoid a visit to the ER, because it's a place where the lights are bright, the noise. It's really not where a migraine patient really wants to be. So this is why the medications per se are limited. Again, sometimes really is insurance, because sometimes they end up giving us less triptans than what we actually want or need. And we know that amount will not cause the medication overuse. Interestingly, for the GPANs, we have not seen that they are causing medication overuse headaches, which is a really good thing so far.
That is good. Yeah.
Mhm.
I've had some patients who say that the triptans work a lot faster than the newer medications. Do
And
you
I
see that
think
too?
And I think it's true. And I
Mhm.
think all the studies, if you compare the triptans to this GPANs, it's true. The triptans are still much faster, I think. And this is why the staff spread, which is the GPAN to nasal spray, came out, so that to bypass some of that system and make it work faster. But
Mhm.
I would agree. And we still use triptans in our population. So I don't think GPANs came to completely remove and take triptans out of the market. I think they're specific for a certain population, and the triptans are specific for other population, right? Like
Mhm.
in patients who their migraine escalate extremely fast, and they don't have cardiovascular risk factors, they can use triptans, and that is perfectly fine, and that one will work better, right? Because again, the GPANs really do take much longer. Sometimes they can cause also more GI symptoms and upset stomach and constipation issues. So I don't think it's a one fit for all, right? That's when we talk to the patient, assess their risk factors, really understand the history of how their migraine evolves. If they notice that there is a prodromal phase and what they actually experience, and if we can treat right then and there. So yes, it's to your point. I still think that triptans work faster.
Before I ask the next question, is there anything else you want to say about the acute treatment?
So, and in addition of those medications per se, then we still use the DHE, we use nerve blocks, and for severe attacks, we use the greater occipital, the lesser occipital, the supraorbital, auriculotemporal. And then we also have the neuromodulation devices. Oh, and I'm sorry, before I move to the neuromodulation devices, that also can be used for acute treatment. We also can use SPG or sphenopalatine ganglion blocks.
So earlier in the episode, you mentioned constipation, and all I'm thinking is there's a supplement out there that actually treats constipation, but it also, some people think, helps prevent migraine. So I'm referring to magnesium.
Magnesium,
Are
yes.
there any other
So,
supplements? And please tell us all about magnesium.
yes. So, yes, there are other supplements, but going back to magnesium, and I love magnesium. I love recommending magnesium as well. I think magnesium is one of the brain's natural calming minerals. And just like what we were explaining, migraine brains are hyperexcitable. And it's almost like children who have had too much sugar, right? They are like bouncing off the walls. That's our migraine brains. And magnesium tends to calm it down and relax it. But it does this by multiple ways. It's not just one. So it stabilizes the nerve cells, reduces the glutamate, which it kind of counterbalances the glutamate, and the glutamate is actually the brain's major excitatory neurotransmitter. That's where truly the magnesium will help, because it helps regulate that glutamate. And so that's how truly magnesium ends up helping significantly. It also modulates the NMDA receptors, which NMDA receptors also amplify pain signals. So the magnesium kind of acts almost as a natural break, if you will. And it also helps reduce the cortical spreading depression. So magnesium also has been in research, it has been proven to also reduce aura symptoms. It really is it's good for reduction of aura, reduction of headache, calming down the brain itself. It has also been shown effective in reducing the allodynia, which is the pain that after a migraine or during a migraine, sometimes even just touching, you can't even brush your hair, or even just touching your hair hurts. So that's the pain amplification. Basically, magnesium helps with that. And it helps with sleep, which helps also, right? So many patients with
Mhm.
migraine have sleep disturbances, and so it also helps with regulation of sleep. So again, it helps in many ways.
Absolutely. It's funny you bring up the allodynia because, like, when I remember learning about migraines in residency, or maybe it was, I'm sorry, med school, I remember it's treat immediately to prevent
Mhm.
cutaneous allodynia. So, like what you just
Correct.
described, which is so true for sure. I feel like if you get that, you kind of miss the boat on treating the migraine sometimes.
Correct. You missed the boat on treating it
Acutely,
early, but
right?
there's still, yeah, you can still get ahead and, yeah, with treatment and still avoid it. But
Yeah.
for sure, yes.
All the different pathways and neurotransmitters and everything. It's no wonder that you need a fellowship in headache medicine because there's so much one that's like new. I think even since I was in residency and things like that, that it's just amazing all of the, I guess, the progressions in medicine. So it's
Oh, and everything, and there's a lot more coming. I'm actually
yeah.
going to be joining the American Headache Society tomorrow. It starts in Orlando. And I attended the one in Scottsdale, Arizona in December. And it's now we have been overwhelmed with the CGRP for the last, they really started coming out in 2018. But now it's like we're just talking about the pay cap. So now it's a different receptor and the different new medications that are coming or being researched for these, and what kind of, it's going to be so interesting because now we know that some disorders are actually have more pay cap and CGRP. And so we're going to be able to treat post-traumatic headache in a different way than migraine, in a different way than cluster headache, in a different way that is, to me, is just fascinating. And with more research, we'll be able to target the specific therapy for specific patients. So it's exciting. It's definitely an exciting time.
Yeah. So are there any other supplements or anything for
Oh yes. So
pain?
going back to supplements, yeah. So we have data for vitamin B2 or riboflavin. We also have data for there's actually newest data for thiamine or
Mhm.
vitamin B1, but it's not the one that we have. The B2 is the one that we had been recommending in the past. This is new, and there's not that, it's only, I think there's only 2 research studies that have shown improvement in patients with vitamin B1. So for now, we're still, like I said, B2. CoQ10, coenzyme Q10 is
Mhm.
another one that we recommend. And those are the main 3. There are other ones, but then may interact with other medications, go through the liver. And so I tend to be a little bit more cautious. Like, for example, with the feverfew and butterbur and stuff like that, they go through different pathways in the liver, and they can sometimes hurt the livers, right? So you want to try to I usually start with the basic magnesium, B2, and CoQ10, and then move on from there.
Awesome. Is there
Yes.
anything else you'd like to share?
I think just more of what I said. This is an
Yeah.
exciting time to be in, participate in the headache world. So if you are someone who suffers from migraine or know someone who is disabled by migraines, please don't hesitate to reach out. There's so much treatment out there, good treatment options with minimal side effects. Again, non-pharmacologic treatments. There's no reason to be suffering anymore in this age. So yes.
Thank you for listening to the Get Healthy Tampa Bay podcast. A special thanks to Dr. Monica Esposito. If you found this episode helpful, please subscribe, leave a review, and share it with someone who wants to be proactive about their health. Until next time, stay healthy, Tampa Bay.